but I kept Friday open. Just a quick recap, but I think from Monday, we start exam recaps actually. So you didn't miss much, but your class rep said yes, so I thought let's do it. So you have 3 minutes, please. I'll share how we'll do the exam reviews this week because it's just 1 week that we have. So won't be easy. Is it a snowstorm tomorrow? People are coming to school, right? Or is there no news about that? Because I start
heard that
early.
it was going to be bad.
Right. And I think my class is master, it's 10, right? Right in the morning. I gotta,
Yeah, 10 a.m.
you got to check in the morning, maybe. No news so far, I know that. But keep an eye. Keep an eye on is it in the morning, maybe would be better. No news yet, I know. So that you don't miss your class if it's on Zoom. So far, it's in person. Let's see. Okay, we'll start in 2 minutes. Get in yourself. Sure. Ah, okay, everybody, let's get ready. You can hear me well, and can you see the PowerPoint? Everybody?
Yes.
Yes, great. I'll start sharp at 6, please. I'll tell you what's the plan of exam recaps for renal, reviews for renal, because it's only 1 week. So let's see how we can finish the whole recap in a week. But I think I would highly encourage you to attend these recaps, so at least you are not lost. It's a lot of material, believe me. There are 6 lectures and you have 24 questions. And this is your last chance to get a good grade, believe me. Okay, so it's 6. So please let me tell you, first of all, how I'm planning my exam reviews this week, because it's only 1 week. Secondly, please know it's a very good chance. Some people want to get an A, some people want to get a B, some people want to pass. So please see that there are a lot of questions, 24 questions. I want you to do well. Tell me how I can help you, but this is what I thought can help you. So please see that this time I'm going to post this recap, which I will label as recap 1, 2, and 3. My plan is to do your exam review in 3 sessions, Monday, Wednesday, and Friday. I have posted the time, but there are 6 lectures. Each exam review will be 2 lectures so that we are not rushing on the session. Today, I'm going to go over nitrogen balance and urea. I will start amino acid metabolism, but see that amino acid metabolism is being taught tomorrow. So I will just start it, but I will review this section on Wednesday at 6 p.m. So please, first of all, do you see my slides? So you have 6 lectures, you have 2 CV, there are 24 questions. When you compare and contrast today's lecture, which is protein digestion versus urea cycle, please, please, and please do urea cycle more than protein digestion for sure, because it has a lot of steps. and lot of concepts. Did we talk about amino acid pool? And did we realize, sorry, I'll go slow, please. I'm doing 2 lectures per day so that you know well. You can ask me question, but believe me, let me do a recap. I will do question and answer. I'm very happy that your exam is not Monday, so you still have time to ask questions. First of all, did we talk about amino acid pool? You know, proteins have no storage, right? Are proteins stored like carb and lipid? Carb as glycogen, lipid as tags. Did I talk about any protein storage? No, that's why we talk about this big amino acid pool. Just a second, please. You can see the slides, right? Some processes give to the pool, some take away from the pool. So what can give to the pool? Synthesis of non-essential amino acids. So are you aware of the word essential, non-essential, and conditionally essential? If you're not, please make yourself aware of these 3 terms. Absolutely. So what types of amino acid can be synthesized in your body which are non-essential? So non-essential amino acid, if I ask you, do they need to be supplied in the diet? Do non-essential amino acid need to be supplied in the diet? Yes or no? No. Also, those amino acid defect leads to inborn errors of metabolism. I'm not doing inborn errors of metabolism today, but please know all the inborn errors of metabolism. Should you go clinical in this block? Absolutely. But this block is very similar to the last block where you should go clinically, go back to the step. I told you in this slide, relate protein intake to nitrogen balance to ammonia. So for example, if there is hyperammonemia patients, so should you be familiar with patients with hyperammonemia? Absolutely, there's no doubt about that. So in patients with hyperammonemia, is glutamine high too? When ammonia is high in the body, is glutamine high? Yes or no? Yes, please take them together. Then we'll do a differential. But when ammonia is high, it circulates as glutamine. Secondly, if there's a patient of hyperammonemia, what would you restrict in the diet, patient's diet? Purines, pyrimidines, or proteins? Proteins, purines, or pyrimidines? Protein. So you got to be specific. That's why you should know protein intake equivalent to nitrogen balance, equivalent to ammonia in your body. Then please take this as your, I don't share line diagrams because I love them, right? I share line diagrams so they help you keep focus. What I need to do, okay, great. So what I need to do for my protein, first do protein digestion and absorption. How are proteins absorbed? Amino acid as well as peptide. Do you know that amino acid is sodium symport? And peptides are H plus symport, but both are absorbed. Then you don't talk about storage in protein, amino acid pool. Once amino acids are digested and absorbed, they are picked up for utilization or catabolism. First, learn disposal of amino group. Please, the remaining carbon skeleton, don't waste your time in doing the reactions of that lecture. First, do disposal of amino group. So if you ask me protein digestion versus urea, first you should do urea cycle. Yes, it's a symport. I would call it a symport when you talk about amino acid and peptide. They are symports, right? They need sodium. Amino acid needs sodium and peptide needs H plus for absorption. Now, when we talk about, if you ask me protein digestion and urea, please do urea cycle more than proteins digestion. If you ask me amino group disposal, carbon skeleton, please do amino group disposal more than carbon skeleton. I will tell you today's lecture, when I finish at the end, how you have to do carbon skeleton. But yes, when you talk about amino acid catabolism, first you got to get rid of amino group. Why? Why am I always talking about getting rid of amino group? Because amino group will be released as what? What will amino group in the body be released as? Big time. As Not urea, first ammonia. Urea is not formed first. Amino group is first released as ammonia, and you got to take care how this ammonia can safely go into where? Where can ammonia be safely released? Which three tissue I told you? You can, uh, uh, what did you spend a day on? Protein digestion? Protein digestion is a small section. Anyways, so let's go. Liver, kidney, and intestine. Absolutely. Liver, kidney, and intestine, you can release ammonia and they will be safely disposed. So first you do amino group, carbon skeleton, I will tell you. This section and this section will come later, but I will encourage you from now. Please start making for the last section. Start making the list of amino acid and what important compound they form and don't flip-flop them. For example, does tryptophan form melanin or niacin in your body? Tryptophan forms melanin or niacin in your body? Niacin. So when I'm saying tryptophan forms niacin, find out who forms melanin. So this is how you have to make the right list of amino acid and the products. Don't flip-flop them. Yes, very good. Tyrosine forms melanin, not tryptophan. So you can flip-flop that. I will tell you when I address this section, but don't only you got to make a list of amino acid and the important products and don't flip-flop them. That's all. For protein digestion, I clearly told you. Are you following my pace? Everybody is good? Because I don't want to rush into the section. I want you to clearly know what is the focus of the section. Great. There you should know there are proteases, peptidases, but don't forget site. It's important. Renin and pepsin, are they gastric or intestinal? Renin and pepsin, are they gastric or intestinal? Renin, pepsin, gastric. But when you say pancreatic proteases and entropeptidases, where are they functioning? Gastric or intestinal? What do you relate them to? Intestinal. Do you know importance of entropeptidases? Absolutely. It activates, yes, entropeptidases is intestinal, not gastric. Pancreatic proteases are made active in the intestine. Also, you should know the correct list of pancreatic proteases. Is renin a pancreatic protease? Is renin a pancreatic protease? Is RENNI and renin a pancreatic protease? No, so please don't put it there. You got to know this list very well. And also, entropeptidase only activates trypsin, which in turn activates other proteases. So you got to understand the proteases versus peptidases. You got to understand site. You got to understand GI versus intestinal. You got to keep this pancreatic proteases list very correct. Don't flip-flop it. Don't add or subtract from it, right? Does that make sense? Then we talked about each aspect. I told you to distinguish gastric from intestinal digestion. Both amino acid and peptides were absorbed. Amino acid by sodium import, peptide by H plus import. Trypsin. Who activates trypsin? Entropeptidases. And trypsin then activates other proteases. So does trypsin activate pepsin? Does trypsin activate pepsin? No, so don't put it there. So you got to be careful about your list of pancreatic proteases, role of entropeptidases, intestinal versus gastric. So I hope you have the focus. Acidic conditions do, yes, acid will activate pepsin. Yes, acid will do. Then we did cystinuria versus Hartnupp's disease. So what was the common finding for both of them? Gross amino acid urea. Then you distinguish. So if you see, please, in this section, all you got to do is there are two conditions. There's a common finding, but can I pick the right disorder still by differentiating? That should be your focus, which was like the last exam. So gross amino acid urea, amino acid in urine should not, don't jump to cystinuria or Hartnupp's disease. But when I'm saying gross amino acid urea, are you thinking of PKU? Are you thinking of PKU? No, when you think of PKU, you will see more CNS changes. Similarly, I will tell you that there are very characteristic findings. It's not that it's an absolute statement, but there is a more characteristic finding with every disorder. Please relate it to first. Don't mess and mix them up. So cystinuria versus Hartner's disease, one finding which is very important is amino acid in urine. But if I say gross amino acid urea, cystine stone, coal, it's not coal tar. What am I talking? Cystinuria or Hartnupp's disease? Cystiniurias. But what was very important is your gross amino acid urea. If you see black urine, would you pick cystinuria or Hartnupp's disease? If you see urine turning black or black urine, would you pick cystinuria or Hartnupp's disease? Black urine. Anyone? No, black urine you will pick neither. Neither. Black urine you will learn later. I will introduce. So all I'm saying is alkaptonuria. Yes, it's good you know that, but I don't expect you to know that. We have not taught that. But see, I did not teach. Did we learn black urine in cystinuria or Hartnupp's disease? Did we learn black urine? No. So all I'm trying to bring to your attention is what would be the cardinal finding of this disorder, gross amino acid urea. And are you aware of the endogenous source of niacin? Now, but don't stop here when you finish this section at the end of the week. Though tryptophan forms niacin, please complete the list of tryptophan, what else it forms. Tryptophan forms niacin, melatonin, and serotonin. I'm just giving you example. I'm not expecting you to know that complete list right now, but I'm just telling you, you got to complete the list. You cannot just say tryptophan, niacin, I'm done. No. Tryptophan forms niacin, melatonin, and serotonin. So that completes your list, right? But I'll introduce slowly all of them. One you have introduced. What are you going to do this with this big section? Please don't flip-flop tissues. Don't understand first transamination, then deamination, then urea cycle, and transport form. Which is the major transport form, glutamine or alanine? Though both are transport form, but which is the major transport form, glutamine or alanine? Major transport is glutamine or alanine? Glutamine. Secondly, tissue is very important. Transamination or deamination? Which one is associated with release of ammonia? Transamination or deamination? Which one is accompanied with release? Deamination. That's why you see deamination. Do you see deamination in most of the tissue? No. You see deamination in liver, kidney, and intestine. Also distinguish the reaction first. What is transamination? What tissue it is there? What is deamination? Where is urea cycle? Where is urea cycle? Which tissue is urea cycle? Which tissue is urea cycle? Liver, right? Don't flip-flop that. Then transport form. Carbon skeleton, I'm just showing you here also, though I will tell at the end of the section. Just know this, please. That's all. Don't do reaction. Carbon skeleton, if converging into TCA cycle intermediate, energy. TCA minus acetyl-CoA, glucose. Pyruvate, glucose. Tell me which amino acid converges into pyruvate to form glucose. You have learned that. There is one amino acid that converges into pyruvate, alanine. Also know their names. And which amino acid is ketogenic? Leucine and lysine. Also know their names. First of all, so amino acids converging into acetyl-CoA and derivatives, why they do not form glucose? Why anything that converges into acetyl-CoA and derivatives do not form glucose? That's why they are ketogenic. Very good. Pyruvate acetyl-CoA reaction is irreversible. Secondly, in TCA cycle, 2 carbon of acetyl-CoA are completely lost as CO2 and water. There's nothing left to form glucose. So anything converging into acetyl-CoA and derivative will never form glucose. And so it is not glucogenic, it's ketogenic. That's all you do for that catabolism of amino acid that I've taught you is understand this concept, not the reactions. Okay. First and foremost, you dispose the amino group. I have told you what's the fate of the carbon skeleton. Just understand the fate that anything that converges into pyruvate, is it glucogenic or ketogenic? Anything that converges into pyruvate is glucogenic or ketogenic? It is glucogenic. So don't flip-flop that, right? And understand the concept and a relevant why. So when you do dispose amino group, please definitely do this more than protein digestion. There's transamination. Okay, no, okay, great. I thought somebody had a question. No, okay, everybody's good. Great, everybody's good. Just a second. So, what do you know about is transamination accompanied by release of ammonia? Yes or no? Is transamination accompanied by release of ammonia? Yes or no? Transamination, is it accompanied by release of ammonia? No. Is it reversible? Yes. Does it require B6? Yes. Do not forget vitamins on this test. Every vitamin and in what step they are involved, you must know. Please note that down very well, right? And there is no clear-cut distinction where they will be formed. For example, what's the principal storage amino acid in muscle? Decarboxylation, yes, decarboxylation also require B6. I'm glad you know, but don't forget transamination first. The list should be clear. When they ask you B6, what should come to your mind? Transamination. Decarboxylation last, but transamination on the top. I will tell you other places also B6 on the top. But if you know decarboxylation B6, very good. So and there's no preference. Why muscle prefer ALT to form alanine? Because this is the principal storage amino acid in the skeletal muscle, alanine. So anything could be formed, right? So you know the right pair. So when you talk about alanine pyruvate, which enzyme will form alanine pyruvate? Alanine pyruvate, ALT or AST? Alanine pyruvate, ALT or AST? ALT. Is ALT an hepatic enzyme? Absolutely. Is it a marker of hepatic damage? Absolutely. Does high ALT shows there is a hepatic damage? Yes, it does. Right? Are you aware of this? Please don't flip-flop this. It's not the other way around. First, nitrogen flows from muscle to liver, and carbon flows from liver to muscle. What is this known as? Glucose-alanine cycle. Where did we learn this cycle? With pathway. Which pathway you learn? Everybody says Cory's. This is not Cory's, please. Cory's is lactate. Lactate from muscle. I'm not talking about Cory cycle. I'm talking about glucose-alanine cycle. Yes, absolutely. Somebody said you learn that in gluconeogenesis, right? Normally, this cycle is on all the time in your body. Yes, because you need glucose in between meals, sleep. But in fasting, starvation, and diabetes, this cycle will be turned on big time. So see how I'm going first towards the reaction, then I'm bringing them back. So you got to understand deamination, release ammonia, transamination, no ammonia. So now, is this step releases ammonia? Look at my cursor. Is this step releasing ammonia? So you got to understand these reactions. No, this step does not release ammonia. So this is not deamination. This is like consuming ammonia. Is step 1 and 2 releasing ammonia? Is this deamination? Is this deamination? The first one was not. Yes, very good. Which is the major deamination, 1 or 2? Which one is major, 1 or 2? 2. What is the enzyme here? What's the enzyme at 2? What's the enzyme at 2? This is glutamate dehydrogenase. Is it a reversible reaction? Is it a reversible reaction? Yes, so be mindful. Transamination is reversible. Glutamate dehydrogenase is also reversible. But since they both release ammonia, where you can safely do them? Liver, kidney, and intestine. Right? We already established that. But since it's reversible, so which is deamination? Glutamate degradation or glutamate formation? Which is deamination? Forward or backward? Forward or backward? Degradation, forward. So it's a reversible reaction. So don't mess up. The glutamate degradation is deamination, right? And glutamate formation is not deamination. And in hyperammonemia patient, did we do that? In hyperammonemia patient, what will happen? This reaction will become irreversible, depleting CNS of alpha ketoglutarate. That's why hyperammonemia signs and symptoms are slurring of speech and blurring of vision. So this reaction is, so first you see what is the reaction. Is it reversible? Is it deamination? Is it transamination? Is it major? Is it minor? And then clinical. Clinical was hyperammonemia patients. So now left or right, which is deamination first of all? Left or right? One or two? Which is deamination? One or two? Right, two. In two also, glutamate degradation is deamination or glutamate formation is deamination? Glutamate degradation is deamination or glutamate formation? Degradation. So see, you got to be specific first, not flip-flopping your reaction, understanding what is transamination, what is deamination, right? I will bring back all the arrows and just give you what are the key points here, because I've already discussed that. I'm not teaching, I'm just bringing your focus here, right? Does it make sense? So let's see what's the key focus of this overall pathway after you have learned clearly what are the reactions. So most tissue, is it safe to do transamination? Absolutely. What is the common product of transamination? Whether it's ALT, ALST, anything, what is the common product of all transamination? One common product, glutamate, moves out as glutamine. So is glutamine a major transport form? Is glutamine a major transport form? Absolutely. And secondly, please, yes, it's a non-toxic form. Or please also understand, if your liver is having any pathology and urea is not being formed, what you can't detoxify? If there's a liver pathology and you can't form urea, what is liver not able to detoxify if you're not forming urea? Ammonia. This will build up, back up, and circulate as glutamine. That's why whenever there is high ammonia in pathologically, what else goes high is glutamine, right? Yes, does that make sense? Please see them together. Can glutamine go liver, kidney, as well as intestine? Absolutely. Does it give up ammonia here? Absolutely. But tell me, one or two, which is the major pool of ammonia? One or two, who contributes? Two, which is what? Glutamate dehydrogenase. So there's a glutamate pool, there's an ammonia pool, but ammonia is detoxified as urea. Site, where are you detoxifying ammonia into urea? Site. Site is liver. Doesn't glutamate? Yes, glutamine definitely releases ammonia, but very minor. This is very minor source of ammonia. Major source is still glutamate dehydrogenase. Yes, glutamine will also release ammonia. No doubt about it, right? Does that make sense? Give me a second. Can glutamine go into the intestine? Yes, ammonia can be safely released here through intact what? What is intact here? That can safely release, transport ammonia into the liver. What is this circulation known as? Intact? Portal circulation, absolutely. Glutamine can go into the kidney too, but for neutralizing the acidity of the tubular fluid. Does that make sense? Also, don't forget this, which we learned as a glucose-alanine cycle, but don't reverse it. It's always what? Nitrogen from muscle to liver and carbon from liver back to muscle. This is known as glucose-alanine cycle. Where did you learn it in? Gluconeogenesis. So bring everything together. Then do urea cycle. How many nitrogen urea has? One, two, one or two? Two nitrogen. We are only interested in nitrogen of urea. That's why you do blood urea nitrogen. I hope you're following my pace. Is this helping? Yes, great. So blood urea nitrogen you are interested in. Who contributes to the nitrogen? First ammonia, second aspartate. So should you know urea cycle very well. I will encourage you to draw the urea cycle and steps. Do hyperammonemia 1 versus 2? Absolutely. More common disorder. Do that. Is it cytosolic as well as mitochondrial? Absolutely. Under hormonal control? No. Site, liver? Yes. Rate limiting CPS1. Is there a CPS2 too? Do you have a CPS2? Yes, CPS2 is for what pathway? It's a rate limiting enzyme for CPS2 is rate limiting for pyrimidine synthesis. Don't flip-flop that, please. NAG. I'm not nagging here, but NAG is important. NAG is N-acetyl glutamate. Why NAG is an activator? It just tells you it's well-fed state. You have acetyl-CoA. You're going to Bexa's well-fed state. You have glutamate. So will glutamate turn on urea cycle? If you have too much glutamate in the liver, will it want to turn on urea cycle? Absolutely. And why arginine turns on urea cycle? Because it's formed from urea cycle. So that is why you should know NAG is for CPS1, no other enzyme. It needs ATP. You should know hyperammonemia. Absolutely. I am not doing 1 versus 2 here, but at the end of the week, I will just know 1 here. Rate limiting enzyme activated by NAG and arginine. So importance of each step, please draw the urea cycle, compare especially 1 versus 2. So I told you 1, rate limiting, hyperammonemia 1. 2, not rate limiting, but hyperammonemia 2. NAG is activating CPS1. 3, the second donor of nitrogen, aspartate. Who forms aspartate in the liver? Who should form aspartate in the liver, ALT or AST? Aspartate should be formed by ALT or AST. Is AST deamination reaction? Is AST deamination? No, it's transamination. So know the difference between transamination, deamination. Then know which is major deamination, which is minor deamination. Very important. 4 just give you 2 important intermediates, fumarate and arginine. And the last step gives you urea. Now let's do 1 versus 2. So do urea cycle, draw it. No CPS1 rate limiting, no partly cytosolic and mitochondrial. Do not forget these 3 things together. If you see these 3 things together in the question stem, where is the pathology? Tell me. If you see these 3 things together, where is the pathology? Liver or kidney? Liver. But then more common cause of this 3 together in your blood is liver disorders. But since we are also doing urea cycle enzyme deficiency disorder, please do them also along with it. But when you do urea cycle enzyme deficiency disorder, please be very, very mindful of the step. And how would you recognize the step? For example, hyperammonemia 1 versus hyperammonemia 2, which is CPS1 deficiency. Hyperammonemia 1 versus 2, which is CPS1 deficiency 1. First, know that. Secondly, in hyperammonemia 1 versus 2, where will you see low carbamoyl phosphate? Where will you see low carbamoyl phosphate? 1, not 2. So that accumulation of substrate and depletion of product is very specific to the step. You cannot flip-flop that, right? So as I asked you, 1 versus 2, look at the left side. 1 versus 2, where is carbamoyl phosphate low? 1, not 2. Secondly, please do not forget that, as I told you, you got to understand in this exam that there will be a common finding that will confuse you, but there will always be 1 differential or 2 differential that will tell you what's the conclusive finding. For example, high ammonia, high glutamine, low BUN, and low carbamoyl phosphate. What is your confirmatory diagnosis? High ammonia, high glutamine, low BUN, and low carbamoyl phosphate. Is there any confirmatory diagnosis you can make here? Low carbamoyl phosphate. Yes. What would be your confirmatory? CPS1 deficiency? Absolutely. I want you to go there. Now, so what will differentiate hyperammonemia 1 versus 2? Because in hyperammonemia 1 versus 2, you see both high ammonia, high glutamine, and low BUN. So what will be high in hyperammonemia 2? That you will say confirmatory, it is OTC deficiency. Very good. Orotic acid. What else? Orotic acid could be high. You cannot say when orotic acid is high, will you pick CPS1 deficiency? If orotic acid is high, will you pick CPS1 deficiency? No. What else? What else is high? You will never pick uracil. I like that. If uracil is high, you will not pick CPS1 deficiency. What about what else? Carbamoyl phosphate. If carbamoyl phosphate is high, you will not pick CPS1 deficiency. So please add this edit. I have made it recently to include orotic acid also. It was not in your lecture slides. But anyway, I will also share this recap 1, 2, and 3 with you with the latest edits, right? With treatment, don't do too much about the treatment. What is the problem here? Ammonia is high, glutamine is high. Yes. Is this the problem here? Is ammonia high in these patients and glutamine is high? You just got to get rid of it. Who gets rid of ammonia? Benzoate. Who gets rid of glutamine? Phenylbutyrate. That's all you need to do, not details of their mechanism. Understand you got to get rid of ammonia, sorry. You got to get rid of ammonia as well as glutamine. That's the only supportive treatment you can give. Right? I still want to tell you the carbon skeleton. So are you clear with what you got to do? Now we dealt with amino group disposal, right? Have you identified all these reactions? I'll give you a quick 2 minutes break. Do you have any questions so far? Anything that is confusing you, you're not clear? Everybody's good? So we could do the last segment for today. Please see, I'm doing it in segments because you have not learned the other lectures yet. Tomorrow, once I do carbon skeleton and inborn, Wednesday we will recap that. Yes, tell me your question, please.
So for hyperuremia 1 and 2, ornithine is only high in hyperuremia 2.
Hyperammonemia 1 versus 2. Okay, let's go back quickly.
Because I'm looking
Hyper
at the image and
Sure. Let's go back.
because
Hyperammonemia 1 versus 2. So what is your question?
so
Ornithine,
in
yeah, both could be high. But remember that carbamoyl phosphate is more differentiating 1 versus 2. That's why
okay,
carbamoyl phosphate is being used as a differential. Yes, ornithine will also accumulate. Whenever there's an enzyme deficiency, anything above the block accumulates and
okay.
products behind the block are depleted, right? But carbamoyl phosphate is differentiating, so that's why it's clinically measured. Did I answer your question?
Yes, ma'am. Thank you.
Great. Yes, absolutely. Anything above the block. So now let's go to the carbon skeleton. All I want you to do is understand what will happen when these amino acid carbon skeleton will converge into these four fate. That's all. And you please don't memorize reaction. For example, do you know alanine forms pyruvate? Yes or no? Do you know alanine forms pyruvate? So what can alanine give you? Mainly because alanine is forming pyruvate, what will it will give you? Glucose, absolutely. Primary first. Secondly, is aspartate forming oxaloacetate? Does aspartate forms oxaloacetate? Yes. So what can aspartate give you? Since it's a TCA cycle intermediate. What all can aspartate give you in your body? Glucose. What else? What else? TCA cycle intermediate also give you one more thing, energy. So you understand you don't need to memorize the reaction, but understand this concept that when carbon skeleton converges into TCA cycle intermediate, energy. TCA minus acetyl-CoA, glucose. Only acetyl-CoA, ketones. Pyruvate, glucose. That's all you need to understand a relevant why. What are they converging into? And what can they form? I don't want you to know the list of all two. You should know ketogenic. What are ketogenic? Tell me. Look at the blue box. Anything converging into blue box, can it form glucose? Anything converging into acetyl-CoA can form? No. So what are the amino acids that converge into acetyl-CoA and are ketogenic? Name the amino acid that leucine and lysine. Though you have not done that, but I'm just giving you a little food for thought, so that you can come back tomorrow prepared. So just know the fate of the intermediates and what can form what, and do not flip-flop them. For example, if anything converging into pyruvate, will it be ketogenic? If amino acids converge into pyruvate, no, it cannot be ketogenic. It has to be what? Anything converging into pyruvate has to be what? Has to form glucose and will be glucogenic. One of the principles. So you understand ketogenic, glucogenic, and both Yes, I will keep giving you example. You also don't have to memorize the reactions. I will tell you when they will be glucogenic, when they will be ketogenic. When you come back tomorrow, because tomorrow I'm going to teach this section, so I'm giving you also a heads up. Please know the last two reactions. They have been taught earlier too. Have they been reintroduced in this renal block? They will be. They will be. So do you know this cascade? Have you learned this? Is alanine coming from skeletal muscle? Yes. Is it forming glucose? Yes. Have you done this propanol-CoA, succinyl-CoA pathway earlier too? Is it glucogenic too? Yes. So please at least know these two pathways. In any of the substrate in the second column, have I mentioned acetyl-CoA? Have I mentioned acetyl-CoA? Yes, it will be liver. If it's gluconeogenesis, it will be liver. Have I mentioned acetyl-CoA in the second column as substrate anywhere? Have I mentioned acetyl-CoA anywhere where my cursor is? No, because acetyl-CoA is glucogenic. Is it glucogenic? Is acetyl-CoA glucogenic? No, absolutely not. So leucine and lysine are purely ketogenic. So do this distinction of what they converge into and what will be their fate. Do not memorize reaction. Just as you already know alanine forms pyruvate, so alanine will be glucogenic. Secondly, please be familiar, distinguish these three terms: essential, non-essential, and conditionally essential. What do you mean by conditionally essential? I'll just give you one example. Do that for me so you don't flip-flop them. Conditionally essential amino acids are all those that become essential only under certain conditions. And which one are those? For example, urea cycle. If there is a urea cycle enzyme deficiency, do you want to supplement arginine? If there is a urea cycle enzyme deficiency disorder case, do you want to supplement arginine in that patient's diet, especially if it's a growing child? Yes. So arginine became essential under conditions. What condition? Pathological condition, like urea cycle enzyme deficiency disorder. I'll give you one more example. Don't memorize the reaction. This reaction, the phenylalanine tyrosine, you must know very well. Hydroxylase, cofactor. But look at this. What can phenylalanine be or tyrosine be? Glucogenic, ketogenic, or both? Just looking at this, it can be both. That's all you need to know. So if the question stem says this amino acid is converging into fumarate and estroacetate, well, this is both glucogenic and ketogenic. So please do not memorize these reactions. But yes, you should know phenylalanine tyrosine conversion, right? Just quickly, give me a few minutes. I just want to do this quick recap, just 2-3 more slides so that you can be prepared what I'll be talking tomorrow. So when I come back tomorrow, I'll just discuss the fates, why that's fate it is. You don't have to memorize reaction, just I'm explaining you here. But please know this reaction very well, PAH versus tetrahydrobiopterin. Please first know normal, then you will know abnormal. Then tomorrow when I come, I will distinguish PKU, which is classic, from cofactor, which is non-classic. But do this reaction, normal reaction first. Also, please understand when I'm saying phenylalanine hydroxylase, hydroxylases require vitamin C. Do hydroxylases require vitamin C? Any hydroxylase require vitamin C? PKU, yes, very good question. In PKU, tyrosine also becomes essential. So that is known as conditionally essential. So any hydroxylase that require vitamin C? Any hydroxylase that requires vitamin C? Have you learned that? Hydroxylase that require vitamin C. Not here, you learn prolyl hydroxylase. Why I'm bringing to your attention? Yeah, for collagen. So you see hydroxylate, don't jump to vitamin C. Phenylalanine hydroxylase, tyrosine hydroxylase, tryptophan hydroxylase do not require vitamin C. What do they require? Phenylalanine hydroxylase. So first of all, phenylalanine hydroxylase requires tetrahydrobiopterin. Does phenylalanine? Yes. Which other hydroxylase require tetrahydrobiopterin? Tyrosine hydroxylase as well as tryptophan hydroxylase. So for before you come to the pathologies tomorrow, please do one thing for me. Do note the enzymes and their cofactor. Keep them in the right place so you don't mess up when they test you on pathology. So not only phenylalanine hydroxylase, tyrosine hydroxylase as well as tryptophan hydroxylase require tetrahydrobiopterin. I think rest we will do tomorrow. So do the normal reaction. I will discuss pathology tomorrow. That's all for today. We will do next the other slides on Wednesday once I have taught you. I hope this helped everybody. Great. I wish you all good luck. Next would be Wednesday. Great.